So really today I have the pleasure, really pleased like the Lillian Shirley. And this first person I know have a two first name as name. I always, is it Shirley or no, it's Lillian Shirley. Yeah, here. Lillian is the new director for the Oregon Public Health Division of the Oregon Health Authority. So it's probably 4 months or ish.
4 months and 2 weeks.
4 months and 2 weeks, exactly. So Lillian received her bachelor degree in nursing from the University of the State of New York, a master's degree in public health from Boston University, and a master's degree in public administration from the Kennedy School of Government at Harvard University. Very well educated, as you can tell. But that's not what Lillian is doing. Lillian is our employer of all our students in public health. Has plenty of the leadership and experience. So it has been a local and national leader in advancing public health. Before coming to Oregon, which is before 1999, that's my understanding, I just asked. She was the director of public health for the city of Boston and was also the first executive director of the Boston Health Commission, where she led the agency through the establishment, design, and organization of the new public health authority in Boston. That's quite a few years ago, 15 years ago. After moving to Oregon, Lillian has been the leader in Oregon's effort to transform our state's healthcare system, while at Multnomah County Health Department by itself is empire already, we all know, for the last 15 years. And on governing board of the Health Share of Oregon, she helped launch one of the first coordinated care organizations in the state. She also served as the vice chair of the Oregon Health Policy Board and has played a vital role in the state's move towards a healthcare system that works better for all of us. So Lillian has served on the boards of the Public Health Foundation, the Oregon Public Health Institute, and the Portland Sustainable Development Commission, and has served as the president of the National Association of City and County Health Officials. She is also adjunct faculty at OHSU School of Medicine. We're going to change that pretty soon. Have to have something with us. Sorry. She received the National Public Health Institute's Balderson Award and has been recognized by the Research America as a public health hero. You know that credential, but you know what I like Lillian the most? Because we have an Oregon Public Health Association meeting every October here. When Lillian and I talk about it, and she said, I am the employer. I can help you with your newly accredited School of Public Health to produce the product that we can use, and I will hire, because it's not a silo. And then she spoke the language as we've been working on ever since the last September. We have integration of a curriculum, and all that with the idea is that when the student get out of here, who is going to hire them? What skill do they need for people like Lillian will hire? Because right now, she has all the vast experience, all the things that we need to really help our student and our faculty for our curriculum, for our education, so we can produce the product that really fit today's the workforce. So, and more than that, when I said, I need you to come as soon as you can, he said, I have a new job. I really have a big job, So anyway, I asked Marie for the Friday, can we invite her? She's the first one to say yes, and is here. So with that, I have a beautiful day for you.
Yeah, absolutely, absolutely.
So, Lillian, thank you for
Well,
coming.
thank you, Tammy.
Yes.
That was kind of an overwhelming introduction. The main purpose of it was to let you know that I'm really old, because if you just kind of follow the chronology. But I'm going to tell you two stories that are in one there that I think will help set the stage for today. I know there's a number of you who are students, but right now I just want to talk to the faculty a little bit. in there that came out was when I was in Boston and I was stuck with setting up this whole Boston Public Health Commission. And so I spent a number of years in large high-rises in lawyers' offices. And we did the best we could to really have a structure that would follow the form of what we wanted for Boston. And when I finished that, the way I got to Harvard was we spent a couple of years, and it could have gone on forever. You're all academics, you know that. These things can go on forever. But one of the things we decided was, I don't know, around March or something, it doesn't matter anymore after 2 years of planning and meetings and community meetings and labor forums, et cetera, and lawyers, lots of lawyers, to create this full asset merger. We decided, okay, it doesn't matter what the question is from now on, the answer is July 1. So we just moved ahead to that. And I think that some of the best minds in government, as well as kind of civic engagement, were involved in how we formed that. But one of the things that struck me was this 2 years of work while I was leading the Boston Public Health Department and we were setting up the Boston Public Health Commission. One of the things that really hit me was, what were the skills that I needed? What did I notice were my gaps? And a lot of people have said, when I went to get my MPH, people said, well, why didn't you go to Harvard instead of BU? And I said, because I didn't have to move the car, because Boston Public Health Commission and Boston City Hospital were right across the street from the Boston University School of Medicine. But when I went back and I got a Rappaport Fellowship to do this work, people said, well, why didn't you go to the Harvard School of Public Health, and do one of their year-long things? And I said, because the skills that I needed that I didn't have if I was going to stay in administration and leadership, I went to the MPP for it, the Masters of Public Policy. So I'm not saying, close down and merge with the Master of Public Policy, but just to think about when you get to that next level beyond management and leadership in systems, what are some of the curricula that you really need to move forward? And I had a great year. And I hope I've been able to bring some of that learning to the job that I had in Multnomah County and now to the state. The other thing I just want to share with you is Tammy's right. I got kicked off of my advisory committee as an alumni advisory committee at the BU School of Public Health because I kept saying to the dean, he's still the dean, you can ask him, and we're friends still. I said, Bob, when I was the head of the Boston Public Health Commission, I said, I'm a consumer of our products. And this was particularly around a problem that we were having. Should we have a 1-year master's or, as opposed to the 2-year MPH? And I'm a big believer in the 2-year MPH, and I'll just share that, and then I'll get on with why you all came to hear me talk. But because what I realized when I started hiring people, if you will, if I had somebody who just concentrated in epidemiology and biostatistics or just concentrated in health education, when we hired them in, they hit the ground running. They were doing great. But what I realized was that person then would hit their ceiling pretty quickly. If I took the time to take somebody who had a broader curriculum experience with, public health law and the social sciences and health administration, and don't forget, back in the day, health administration was not really sexy in schools of public health, but there were fundamental things about finance, about the way the system works, the way people get care, the way people get their care paid for, that was, particularly if you're going to worry about, which I think we do in public health in terms of social justice, we worry about poor and vulnerable, and that's a really big piece of it. So, but if I had a new graduate who had that kind of exposure, it might take me longer, 3, 6, maybe even 9 months to get them really up to speed to what we hired them into, sitting in front of a computer, maybe doing analyst or doing, some work with the violence prevention programs or the HIV community programs, but that person had a sense of what it was all about, and that they could make lateral moves and they could move into other areas. And I just want to share that with you because like I said, this is not evidence-based. This is just an opinion. But, Tammy Marie said it's okay for me to have my opinion. So with that, what I'm going to do is, this is why I got asked to come to talk to you about preparing the public health workforce. But that's not really what I want to talk about. I want to talk about what's going on. What is the context that is happening here, both nationally, but definitely, as a lab nationally for what's happening around healthcare transformation here in Oregon. And no matter what you hear on the news or CNN or Fox or whatever, this isn't going to get rolled back because too many people have been covered. It might look different. The flavors might change. They might change the names because there's too much branding around it. It's not going to get rolled back. This is here and it's happening. And the place that you can bet that this is kind of, this opinion that I'm having you can check out is the Catholic Hospital Association of America and the American Hospital Association, not the most progressive social justice crowd, but they know that the way we deliver care, organize, and fund care in this country is not sustainable. So when these people get on board, we're going to go in a direction, maybe not all together, but we're moving in this direction. So that's why it's so important for those of us who believe that kind of the secret sauce to all this health stuff is public health, really understand what's going on. So that's a long-winded way of saying what I want to start out with is really organizing or anchoring what we're going to think about here at OSU in what's going on in Oregon. So this is just by review. We have our current governor played a key role. He's been in this business since the 1980s. And health reform is currently one of his top 3 topics, along with education and early learning. And he has been completely focused on that for his first 4 years. And you might notice they have a lot of synergy around those areas. So what we have in our coordinated care organizations, and I find that there's some mythology around what they are, but they are really take everything that you can to keep a person healthy in the clinical system for Medicaid clients, so they have a global budget. And I'll give you 2 examples of struggles we're dealing with right now. We're dealing with, 3 actually. So suddenly these people now have all the money for come July 1 for residential mental health treatment. Suddenly they have to get ready to do the targeted case management for young families. These things were never in that. They didn't have to think about those things. Somebody else in the other part of the sector was doing that. So in a number of areas here, actually, or just south of here in Lane County, the CCO decided, we have all these women who are coming in who are at high risk for their pregnancy, and they all smoke. Now, we can, try and get them to, stop smoking. The provider will talk to them. We'll give them patches. But what are the other things that we can change? We can engineer the environment around smoking, and they are now giving money to the public health department there in their county to do that upstream work, realizing that is not theirs to do, but that's the linkage that's happening. A couple of other places in my area, the CCO that I was involved in setting up, Health Share of Oregon, we got a bunch of money from the feds, and it was for hot spotting and for people with, multiple chronic diseases and social economic challenges. And we actually got permission to use the Medicaid dollars that we were getting not all of them, obviously, but, to peel off some to support housing for certain people that we knew if we couldn't get them in stable housing, it really didn't matter, they would just keep cycling back in with their wounds, with their mental health issues, with their access to medicine. And, understanding that all of these sectors are involved in the solution, hopefully. So just very quickly, this is, and all of these things will be, left with all of you. But in our journey, these are the things that we've accomplished since House Bill 2009 passed the legislature. And you can read these things if you want, but I think it's important sometimes when we get stuck in the overwhelming demands of the present or the disappointments of the present, that's a code word for the technology around Cover Oregon. For us to forget how much we've actually been able to accomplish here in Oregon in a very short period of time. So, you can read all these benchmarks if you would like to. And then this goes up to December of 2014. And I made a phone call last night because I knew I was coming here with or without the technology. I just want you all to know that we have 230,000 Oregonians as of last Friday who now have health insurance that didn't have health insurance on December 31st. And the other milestone in this trajectory in terms of our multifaceted work that we're trying to do is that everybody's heard of the patient-centered medical home. Well, we just also passed, we have our 500th patient-centered primary care home now certified. And we didn't have that as a goal until the end of 2015. So how does that happen? It doesn't happen by the legislature. It doesn't happen by the governor. It doesn't even happen by the public health department, although I would like to take credit for it. It happens because independent physicians, the healthcare payment methodologies that we have in this state, and there's many, and they're complicated, everyone here is really pulling in the same direction. And I think if we were to have someone land on the planet, and the best picture that I have come across, it's not new, it's old, and I have to give credit to the Public Health Institute down in California. They did this a couple of years ago, is this is what we're doing. This is what we're trying to achieve here. And you can see, if you look at that bubble, when people complain, when are we going to get money out of the system so that we can, build recreation centers and do jungle gyms in the park and plant more trees. Yes, that will happen. But we have to start somewhere. And where are we now? This is where we are over here. Oh, if I'm not supposed to walk that far. Of course, I was told. So that first bubble there, the green clinical services, that's where we're trying to take 2% out of the system and incentivize changes in behavior. When I say certified patient-centered medical homes, that's team-based care. That's a little hard for the providers and a little hard for the patients, but it's slowly we're working on changing the concept of how things are delivered and who delivers them, which gets into a lot of the workforce issues that you all have been doing, even with the extension service. I think that work is wonderful. So if you look down the payment models, the incentives, the metrics, and governments down, I'd walk over here if I was allowed to go out of the screen. At each step there are elements of change that will contribute to the whole. And where we are now is, I think, I call it health system 2.0. I mean, the health authority, that's what we call it in the cabinet. We are in that blue space. We are beginning to figure out pilot by pilot, example by example, with evaluation of how do we expand that circle and where do we want to go. And this has been true and I was on the Health Policy Board. It is not an accident that that all these CCOs have to have community councils, and that the community councils have to have significant representation of consumers, 51% of consumers. Now, we stole that from the Federally Qualified Health Center enabling legislation, because all the Federally Qualified Health Centers that have been around since the 70s, that's part of their requirements. You have to have a consumer board. 60% or more have to be people who actually get care in your center, and it's the same idea. You have to have, if you're going to run this for Medicaid, you have to have some advice and input from people who are actually getting the services, who are Medicaid clients. Now, where do we want to go? Now, the jungle gyms and the parks and the trees, that's over there on the far right-hand side. And I think that once we get real aggregate health status and are able to track it, that's where we will have, you'll see the reduced health care cost. And if I can channel the governor a little bit, And he'd say, and that's how we're going to fund education appropriately, K through higher education. We have to, the circle isn't going to get bigger, the pie isn't going to get bigger, but we really need to control, where the money is being spent. And we have to do it, as you know, our whole system is built around the triple aim. There has to be quality. We have to be measuring the quality, not just the fact that the cost went down. And we have to be measuring the patient experience. Is the patient having an experience? The question that we're going to be asking, we're doing a healthy aging kind of beginning 3 or 4 hour meeting in May. And the question we want to ask is, how do people experience their health as they age? Not the professionals, but one of the questions we want to add to the BRFIS study is, how do you feel? How are you feeling about your health? And so to get that kind of independent take on what are people experiencing and not just what we've identified. So those 3 elements have got to be there at all times. So hang on to that. I'm going to come back to that slide. Okay. So again, who's involved in this here? In Oregon, we have our payers and our insurers who will create ACOs in the Medicare model and what we're calling CCOs. We know they're in. We know public health is getting in more and more. I'll give you an example. Just happened this morning. This is a journey. Nothing. There's no book to read on this because it hasn't been written yet. This morning, we just had some people come back from the National Preparedness Summit, which is the public health and hospital preparedness, crowd that meets all the time. And what our people learned, and I didn't even know this, is there are provisions in the Affordable Care Act that says that all of these hospitals, just like, the hospitals now to get their tax reform, their 501c3 status, hospitals have to put how they've done a community assessment, how they're meeting that assessment. Well, it turns out they also have to have in their COOP plan how they're connected with public health emergency preparedness. Who knew, So again, now we have an opportunity to go to the Transformation Center, to meet up with the CCOs, to educate the innovator agents that are deployed throughout the state, and we have an opportunity to yet bring another important element to public health preparedness, into the clinical transformation. So stay tuned. Well, not everything gets worked out the way we plan it, but and then community and social determinants of health, so important. And we could, I could fill up that circle. We've just completed the State of Oregon Division of Public Health. We've just completed a memorandum of understanding with the Department of Transportation. We are in the process of figuring out a way that we can do a memorandum of understanding with the Oregon Department of Education. We've been working with them very closely, program by program, but how do we identify shared goals? And we just had an aha experience just a couple of weeks ago, and I said, well, wait a minute, is it just the Public Health Division, or is it all of the Oregon Health Authority, that we need to think about how do we connect our goals with education? And then, of course, this is what you're reading about in the paper every day, healthcare system, primary care, and the changes around the clinical care system. So we focus on population health, I believe. And the good news is that this construct of population health is on everybody's agenda. So I was on a plane coming back from D.C. with someone from another place in the country who was changing planes with me and going back to California. And this person was complaining. It's like, well, everybody's in the public health business now, and U.S. healthcare, has all this stuff. And I'm sitting there thinking, well, wow, that's cool, Because one of the things that I learned very early on was that I can't do the work of 100, but in public health, our job is to get 100 people working on our agenda. And whether or not we're up front or it's branded as public health, when everyone is, having transparency, community engagement, equity, all of our principles of social justice, when we can get them to make their decisions around that, then, we won. We will get what we want, because ultimately our only stake in the game is a healthy community, So, and this population health connotes a high-level assessment of a group of people, and sometimes we have trouble with our language when we sit down to talk, and I'll give you an example of that. So, if I am an insurer, if I am MODA or Care Oregon, or when I talk about population health, I'm talking about having everybody I'm covered lives I get paid for it, to make sure they get, pay the bills for it, that make sure that they're assigned correctly to a primary care provider, that they're tracked, that, they get quality services, that they get all the benchmarks. Oregon, we have 17 high-level benchmarks that they're all being measured on. You can see how the progress is. The last quarter just got posted last week on the website. And then if you're a primary care doc or a nurse practitioner, you're thinking, or now a medical team, what you mean by population is, you're thinking probably I'm responsible for 1,700 people in my panel of patients. So the team has to worry about, who needs Hep C screening, who needs follow-up for, fill in the blank, how many well child visits, how many people have had their colorectal cancer screening. I'm worried about that population as it fits into my one-on-one encounters. And when populations residing, as for us, we're thinking of them in the broader community. And that can be a geographic area. It can be everybody whose parents came from Samoa. It can be population groups divided differently, but we look at it regardless of the individual health status within the community. And one of the things that it's really important to do, I think, is to, when you sit down for these negotiated projects, etc., you have to say, now, that's what do you mean by that? Or give me what your mental model is, or how would that look like if, from your perspective, it succeeded, And it's probably okay, but what we in public health might want to do is add some other dimensions into that, add some other thoughts and ideas into that. So that kind of understanding, I think, is it has to always be on the minds of the public health practitioner. So you all know this, leading causes of premature death are associated with 4 behaviors. And I think we in public health have always kind of thought we owned these, and we just had this, you're probably more aware of it than I am, the county rankings just came out. And again, smoking is the #1 cause of disease and disability in the state of Oregon, and death. So no reason to move on, from our smoking goals. It's still taking our population down. But now we have all these cool partners under the triple aim and under healthcare transformation. So we really need to think about, we have focused a lot in our health education strategies around individual behaviors, and I think that that's still important. It's still an element. But in public health, we should start thinking more, because we have more people that are going to help us execute that, the 100 that are going to do the work of each of us. But for us to think of all these areas as that are associated with 4 behaviors, but how can we engineer the environment, the policy environment, and the physical environment to make sure that all of this work is being pushed in the same direction? And I think that you'll see more and more ability for us to think that way and not just do one-on-one interventions. Again, these are opinions, Tammy. Okay, this is my best guess. And so I don't know where this fits into this little overview, but I never give a talk without putting this up on the screen. I think that we have to be all, in public health, we say, what is our main science? The science of public health is epidemiology. And the philosophical framework of public health is social justice. We were the people that, went around and said, well, it isn't okay for rich people to have clean water and poor people not to have clean water. This is like way before my grandfather was born, We were thinking this way. We didn't say it that way, but we passed laws, we fought for systems to be built, that had everyone have equal access to the sanitation improvements, that, were the beginnings of the last century. So, I mean, this has been our framework forever. But now we have to be a little more sophisticated because we have to understand that we have to engage the community into answering the questions about what is it about the social environment and the physical environment, and how do we make sure that everyone gets to that well-being and prosperity. But we have to stay in our lane as well. And I think that that's where these MOUs with other sectors come in. And I would say that that's part of what public health needs to do. We've all heard, I'm sure you've heard it before me because you're all academics and you're students, but this concept of health in all policies and the concept of, really understanding the health impact of transportation decisions, housing decisions, etc., that we really need to think through how we get that on the agenda and into other people's thinking. And that social determinants of health piece of it, we can't do that alone. We have to have the affected communities be part of the recommendations that we make, or we'll be making recommendations that will probably work for somebody. I'll make recommendations that will work for me. I'm middle class, I'm white, and I'm, over 50. That may not be the target audience, And so constantly we have to be challenging ourselves to get to the solution, because the solution may be, different in different environments. And that's really hard because we're good at doing strategic planning. We have to figure out a sustainability of our business model and not be fighting over the crumbs, I would say. People are nervous because, United Healthcare is getting in the public health business, and, people are sending out outreach workers, and the great model of peer support in mental health and alcohol and drug and diabetes and asthma. Most of these people are not working in strict public health environments. So how are we connecting with them? How are we making sure that the curriculum and that the certifications are best practices? Because that's the piece of it we own now. We don't necessarily own anymore the delivery. We need to refocus on the key drivers of health and health cost. We have to make sure we can show where we have added value. And that's that rigorous evaluation. And we have to be honest when we don't know if it works or not. We know that we can observe that people get better over here, but we can't go in and say this is going to work. And we have to be honest about the time horizon that we're looking at. And if we can do that, people are they're kind of in it. You know how people talked about churning on Medicaid, on and off Medicaid? I had it for 6 months, and I had to reapply, and when I reapplied, I got sent to another plan. That ain't going to happen anymore. I mean, one of the biggest things that we're dealing with right now in Oregon is we have somewhere approximately 50,000 people that are positive for hepatitis C. And that is one of the most expensive treatments on the market because it's still all proprietary. Before we went into the CCOs, which was about a year ago, 3 of our Medicaid, now who gets hepatitis C? I'm just going to lay that out there. I'm not going to make any assumptions. 3 of our Medicaid managed care plans didn't pay for that because it was so expensive, But now they're going to be their patients forever, and they're not going to churn, and we're going to have coverage. And so if we don't take care of it when someone's in their 40s and 50s, we're going to be paying for, their liver transplant. We're going to be paying for all the accruements of disability that go along with those kinds of diseases, and their hospitalizations on and off. So it's a time to rethink, how we can make that possible. But we also have to make sure, another example, I have a lot of money from the feds to track surveillance and follow up for meningitis. Last year we had 12. Not a rate of 12 cases of meningitis in the state. I have not one penny for hepatitis C. And I know I've got about 50,000 people walking around with that disease. So how do we organize ourselves to change that balance in public health? That's what we should be worried about in Oregon, Maybe in Alabama they need to worry about meningitis, but we have a clinical system that is, can diagnose, treat, find those cases. And we should still keep them in our radar, but where is our effort and our money and our surveillance system going? And we have to better communicate to a public that's very skeptical, not only about, you might not think of yourselves as government, but you probably promote things like smoke-free campuses, licensing where people sell tobacco. It's like, and the major paper in the state of Oregon came out on New Year's Day and said, that's the Oregonian, I'm just being, Tri-County centric here, but they came out but it definitely, you got to admit, it is a pretty influential editorial. They came out, and one of their 3 priorities for their paper for this year was basically getting government regulation out of people's lives. So, how about that? One of the stories that we've been telling people, and the legislature, is I know where we can find 315,000 people who want more government regulation, and they are in Charleston, West Virginia. It's like people don't put these things together, but that's kind of old-fashioned hardcore, public health protection. But if people can get that, we can bring them along, I think. These are some of the things that we've been doing here, initially in Oregon, to transform public health. I'm going to start at the state level because I believe that, I do believe that all real prevention efforts, frequently, what we talked about are efforts to educate the public and educate people, and actually the best pathway sometimes to behavior change is engineering the systems. But we also know that while personal responsibility is important and these things that we do at the state is important, it's really community norms. But I'll tell you what we're trying to do anyway at the state level, to kind of have a holding vessel, if you will, that you can help at the community level make those changes in. So we have established a vision for the state's health transformation effort as a full partner in the Oregon Health Authority. For those of you who have been involved in public health administrative practice and things, for years there's been a tendency in public health to believe that we needed to be our own silo, if you will. And, I'm old enough to remember, how do you get the public health director to report to the governors, and we should have our own area, and that's fine. With this particular governor, I wouldn't mind reporting to him. But here in Oregon and in a couple of other states, we belong to a health agency, the Oregon Health Authority. And that means we are actually able to say, as these conversations are happening, did you think about this, or this is the impact, or that? And I really think if you're going to go out and talk to people about this, you need to go out first and ask people what they think first. Kind of all of our kind of public healthy way of doing things. Recently, we were brought to D.C., about 12 states, the Medicaid directors, the Medicaid medical directors, and the public health directors. And the idea was that an unnamed agency who paid and brought us to D.C., they thought this was really groundbreaking because you were going to get to meet your Medicaid director. Well, I'm on a phone call for an hour every week, twice a week, with my Medicaid director and my AMH director and the head of PEB and OEB, and because we are in this cabinet together. So we're beginning to influence from the beginning. We're setting the metrics for the next round with the CCOs and with Medicaid. What would make a difference to show that the population has a chance at being healthy down the long term? Smoking is one of them. Teen pregnancy. You guys could all tell me exactly what we put. We gave them a menu of 8 and said pick 4 to 6, and they were like, "Oh, cool. This is really great. We wouldn't have thought of that." But it's that that new way of operating, and we're a full partner at the Oregon Health Authority. We're working toward a strategic plan for Oregon Public Health Division in alignment with all the local community health assessments and community improvement plans, as opposed to us having ours and everybody else having theirs. We're actually taking ours out on the road starting next month, May. May. We're in April. We got to April already, right? We're actually taking ours on the road and saying, hey, this is what we're seeing with our capacity, capabilities, and epidemiology, and how does this fit in with what you need to do? Now, it doesn't mean we're all going to be doing the same thing, but it means we need to understand where they're complementary. We applied for national accreditation. We pushed the button, and we had balloons and everything about 3 weeks ago. And we support accreditation of county health departments. And we're developing a public health policy capacity. And I think this is definitely an emerging focus for public health policy development. And I'm just going to lay some of these things out for you. I think that that's a core skill that is needed for the future of public health workforce. And so here comes my editorial comments. I think that part of that is systems thinking, critical thinking. Really, how do people who are trained in, schooled in, competent in, and really performing very well, kind of entry level into the public health workforce for programmatic things. How do you give them the skill set in their graduate education that then they are ready with the critical thinking skills and the systems thinking and understanding how these things all go together? Because if we don't design these pathways, they won't get designed. And my experience here in Oregon the last 2 years is when we're able to say, clear our throat and say, actually, people are like, oh wow, So just things that the public health department has done for a long time. Not the county rankings, but we have these county. Every county we have a whole morbidity and mortality report. Things that aren't just health kind of things like immunization, but how many kids in the counties graduate from high school? How many, that's available, and nobody knew it was available. And I can't tell you how many meetings people have walked away from saying, wow, I didn't know you had that. Philanthropies as well. Understanding that that's a core contribution that public health has to make about where are you going to invest. And what are the things that will make a difference? And that's why we believe in local control. I know I'm supposed to be here as a state health department director, but because those local conditions are different, and we can set the vision and we can set the outcomes, but how people get there will have to determine on what's going on in their own communities, what their resources are in their own communities, and what the culture is around this stuff in their own communities. So that was the second commercial. One of the other things I want to share with you is we have this Future of Public Health Task Force, and I know one person in the room has been there. I don't know, have any of the students been there? Okay, great. So this was created by the legislator, House Bill 2348 in 2013, and you can't read that. I can't read that. I guess we didn't get around to making it bigger, but that's the charge. But what I'm giving you is access to information. That is that link on the top has all of the materials, all of the meetings, where they're going to be, and who said what. And after they present, we put their documents up so you can have all of that. I just want to share the members. The task force is 15 members. You can find that on the website too. But they're appointed by the governor, the director of the Oregon Health Authority, and the director of Human Services. Task force members are Tammy Bainey, who is a commissioner. So we have she's the chair. The co-chair is the director of the Oregon Public Health Institute, and then we have 2 local public health administrators. We have representatives from 2 nonprofits, Philanthropy and another nonprofit. We have Carlos Crespo, who I'm sure you all know is a professor at Portland State. And we have a medical director of a large CCO in Trillium in the valley, in the southern part of the valley. Plus we have 4 at-large members, one of whom is a longtime public health health officer, and we have 4 representatives. We have 4 legislators, 2 representatives and 2 senators. So this is obviously an unnatural act, trying to get everybody to the same consensus. But our goal is we have to, because this is the legislation says this, we have to have recommendations to the legislature by the fall. So 2 more slides, and then I want to make sure we stop. Back to this. This is the template. This is what we're trying to achieve. And I think that some of the things going forward that I would like people to think about is we're looking for people who can be flexible. We're looking for people who can deal with ambiguity. We're looking with people who understand core negotiation skills. These are because you have to keep crossing these boundaries. They're not set in stone. They go back and forth, and they go in different focuses. I think what we bring in public health is a complete commitment to what the outcome is. We need to know what we're trying to achieve. We need to keep focused on where are we going, not attached to a particular outcome, but it's the health of the community. And that's always, that's how we have to check ourselves, with our projects, with our programs, keep going back. Because you can get really tied up in these things, they're fascinating. And the business of healthcare is amazing. I mean, just trying to sort out the quality metrics, trying to sort out the benchmarks that we're trying to use and figure out which ones won't matter in the end and which ones really will make a difference. And then this is, I think, you might wonder how I'm going from the Future Public Health Task Force to this. Okay, so the real challenge is we have to figure out a way that, and I'm sure everybody in this room is very familiar with this pyramid, and there's other pyramids and there's circles, and there's things like that. But right now, the funding for public health is basically at the top two levels of the interventions. And even though we're not talking about, our diabetes things, our high cholesterol things, our clinical interventions around maternal child health, our healthy baby stuff, healthy home visiting, the challenge for the future is how do we prepare a workforce that I feel this is where I'm going to step out again. I feel that this is the two places that we belong. We need to be partners here. This is where health and all policies come in, but we have to stay in our lane or we get all over the place and people are like, well, what are you doing here? So that's the being able to be disciplined about how we go into coalitions, how we go into collaborations, to know, have the discipline of understanding what are our goals here and what's our lane here. Or you get, to me, you just get, a really big swimming pool with everybody kind of no lanes. Everybody's kind of, paddling around, and no one's a clear direction to get to the other side of the pool. So, that's that. So I want to take questions, and I have to laugh. Can I tell a story on you, John? So I didn't know who this guy was. He's on my public health advisory board. And when Dr. Goldberg resigned, I wanted to call them all and see, how they were feeling, and just tell them, it's okay. We're staying the course. We have the vision. We have our work plans. We're moving ahead. And so we got talking a little bit about this talk, and I said, I have to tell you, when young people come in to see me who are finishing their MPH, they often say, what'll distinguish me? Like if I have 10 MPHs coming in June or July, whenever you guys graduate. And I literally have said this recently to two young women. I said, you should take some finance courses. And they looked at me and they said, one was from Northeastern and one was from an unnamed school here in the state. And and they kind of like, I want to save lives. I want to stamp out the AIDS epidemic. And I said, no, seriously, you should take some finance courses. And particularly government financing courses, because that's where you're going to wind up. You may not be working in the government system, but dollars to donuts, you're going to have some relationship, if you're in public health, to some kind of core government funding. And you have to understand how that works. So I said, so if you want to distinguish yourself, that's where I would go. And then, so John's on the phone and he starts, he says, you need to know I teach the finance course. So I'm sure he thought I was just sucking up to him because he's on my advisory board, but it was an honest reaction. So I do think we need to think less programmatically, particularly since more and more schools are starting bachelors in public health, or some, they call them different things, but it's basically a public health skill set. I think for the master's prepared students, we have to start thinking about what are the what are the kind of stuff that I went to the Kennedy School for to get? What was the kind of critical thinking and leadership that I got challenged to really develop and also reflect on? What was the best way? What's the best path forward? So.
Thank you.
Two things I just wanted to say. One, I forgot to mention during the introduction is actually she was the one, one of your early slides, remember you got the timeline.
Yeah.
December 2010, Lillian was the one recommended me to be the chair and co-chair with Lila Wilkie.
That's why when they said, "Oh, you're going to come," you said yes. I said, "I heard big time."
So that's for the beginning of the Oregon Health improvement plan.
Mm-hmm. Right.
Boys, throw somebody in the community, work with 26 citizens, and then they're all over the map, and get them together, and actually based on this slides how we work into, and many of you know that I'm an action person. I want into an action plan. I don't know to thank her or to blame her, but I have to say that was an education. A very educational process.
You had just come to Oregon. This was a good education for you.
Yes, absolutely.
Input is us.
So that's one. The second one I really want to share is that the slide previous one, and maybe you can just go with yes. The three circle, and we actually talk in extension, at least in the planning stage of the 3-stage health system 1.0, health system 2.0, and health system 3.0. We really want to, and even at the very early stage when we did 2010-11, was thinking about health is within the community. So extension, even at the 2010, working with our extension said, we have to play an important role within the community because it's coming. So when we get to 3.0, health system 3.0, I'm hoping as our transition and then really allow the land-grant mission, land-grant university, more than we understand health, clinical care, medical care system, we also really understand the community system of 3.0 because the extension really is the expressway together. So just want to make that comment. The link
no, I
to
completely
our
agree.
Yes.
I completely agree. I think that there's two things that are need to be exploited much better. One here in this where we are now is WIC. WIC is amazing. And they give shots and they refer people to family planning and they give little kids books. And people come in because they get food. And if you look at WIC is a slightly higher eligibility rate than a lot of other programs, and in a state which is a poor state like ours, we're a poor state. The amount of touch points that you have for that population are enormous. We haven't figured out how to really, make it integral to, some of the work that we want. And the other thing I think is the extension service. I think those are two pieces that we haven't done enough thinking about how to really have them have a major impact in what we're trying to achieve in terms of our health for all Oregonians.
Well, we help you to think and then present it to you.